Hello, this is Dr. Pete with another in the series from the Arizona Antimicrobial Stewardship Collaborative. Today we're going to talk about sepsis awareness, which is an important component of stewardship, and it's one that most of our focus, of course, is on people receiving antibiotics for infections they don't have, but it's also at the same time very necessary to have an awareness protocol so that you don't miss an actual infection, particularly a serious one, should it occur. So just to go back and review, our whole protocol is about the root cause of antibiotic resistance, which is people receiving antibiotics for infections they do not actually have. And as our friend Dr. Darren Siski says at Stanford, we are awash in a sea of antibiotics. And the main culprits that we're dealing with are presumed urinary tract infection and presumed pneumonia. And I use this phrase presumed because most of these two entities are treated as if they had an actual infection when in fact they do not. So I like to say presumed. The other way you can say it, of course, is along with Dr. Clifton Meter from the old days, who wrote a little book called The Art and Science of Non-Disease. So we could call these presumed urinary tract and pneumonia non-urinary tract or non-pneumonia just as well, but it's a little more delicate to say presumed. So why is it important to be talking about sepsis awareness? In acute care hospitals, the Stop Sepsis program is a big deal now because we're out to, across the whole globe, kind of shut off the high numbers of people dying of sepsis in acute care hospitals. And there's a reflection of that idea, which we're talking about today, specifically for long-term care facilities. And part of the Stop Sepsis campaign started because of the increased vulnerability of aged people due to immobility and weakened immune responses. And a study some time ago showed that if seniors are hospitalized for sepsis, about 1 in 5 of them will not survive. And it's estimated 25,000 elderly residents die annually due to sepsis. So it's an important topic. A real infection needs to be recognized and distinguished from a misinterpretation of symptoms or diagnostic test results, the sort of presumed urinary tract infection and presumed pneumonia. In a sense, you could say that the sepsis awareness protocol for long-term care facilities is really the other side of the antibiotic stewardship coin. So what would trigger a change of condition alert in a long-term care facility that a patient may be at the edge of an episode of sepsis? Of course, the most important three things are fever, a temperature above 100.5 or below 96.8, and an increased respiratory rate above 25 per minute, and a pulse greater than 100 beats per minute. So whenever that constellation of signs and symptoms is there, then it's good to start initiating the sepsis protocol. And when that's started, the first step is to notify the provider, either the physician, the attending physician, or their nurse practitioner. And before you do that, it's useful to review the advance directive. For instance, the family may have already specified that they do not want any resuscitation attempts for their elderly loved one. And it would be a good thing to know that before you call the provider and let them know that there are preliminary indications that the resident may be suffering from an episode of sepsis, and get them to order a stat CBC. And it's useful to remember that the decision level for significance of a white count is not the upper limit of normal, around 12,000, but rather 14,000 white cells per cubic millimeter. So that's a decision point, if you like, which is above the upper limit of normal. And along with that, another way with the modern CBC instruments, they will report an immature granulocyte count, which is something more immature than the band, and including what we used to call the bands. So an immature granulocyte count, if that's available, anything over 900 is considered significant and will be a positive part of the protocol. And really at that point, the decision needs to be made whether to treat the resident in place at the facility or initiate a transfer to hospital. And you may know that there's quite a bit of a campaign now for long-term care facilities and skilled nursing facilities to minimize the transfers to acute care. So there's a much more emphasis today on treating in place before transferring to hospital. So that's essentially the points we want to get across on the sepsis protocol for long-term care. Just to summarize, sepsis in long-term care residents is not common, but it's critical to recognize that. And the antibiotic stewardship goals are still important, namely to measure antibiotic prescribing in the way that our previous videos have described, to make visible antibiotic overuse, which is really dependent on the correct collection of data in a way that gives visibility to the antibiotic stewardship, and to minimize the misdiagnosis of our two friends, asymptomatic bacteriuria and presumed pneumonia, which doesn't turn out to be at all pneumonia. And lastly, to enhance our own decision-making of the prescribers and the nurses. And this is all around steering the transition in thinking, our mindset around the use of antibiotics in our facilities. And if we do all this correctly, we'll fulfill the goals of diagnostic stewardship, very analogous to antibiotic stewardship, which is specifically to decrease unnecessary urine cultures and to decrease unnecessary chest X-ray. So really, that's all for today. Please stay tuned for more videos in this series from the Arizona Antimicrobial Stewardship Collaborative. Bye.